So, ladies and gentlemen, thank you so much for the hospitality. Daniel, Andreas, Carol, I really feel at home already. I have a very difficult task today. I have to keep you awake after lunch. I know you all would like to go and have a nap. But my name is Daniel Eberli, and I usually don't have a mustache, but it's the time of year again, and the entire team at home, this is after a prostate cancer discussion round, we're now growing the mustaches back. My wife loves, they know at December I can cut it off again. So I have some conflict of interest. I'm the chairman of urology in Zurich. I have a very nice team, and we really try to figure out which patient really needs treatment at all. And if he needs treatment, can we make it a gentle one? So, it's fascinating. We're talking about a little organ. It's less than a mandarin or a little less than your fist, and it's causing so much troubles in this part of the world as well. Here is a graph again, and you can see already that Switzerland is right there, the same number, same density as Norway. We do have a problem. Prostate cancer is an issue that we have to address, not only for our patients, but also financially. These are the numbers from Norway, and you can already see it's like almost everywhere in the world. You die of the lung cancer, but prostate cancer is very, very common. We now know it's 1 out of 6 men that is really has a problem with prostate cancer. This morning I had breakfast in the hotel, and the tables were, 6 people at one table, all the businessmen eating their breakfast. 1 of each table will have prostate cancer. So we have to make wise decisions and really try to help them a long way. And it's even going to grow. We now know as the population is aging, within a 10-year span, we get worldwide 35% of more prostate cancers that we have to decide on whether we want to do something or not. So we do have to understand that the whole bow is important. We talked a lot about screening, and I love the discussions that we had already. Digital rectal exam, just a little quick note, I think is going to lose its importance. We now know from trials that in the younger man, even the finger of the most experienced urologist is a very bad finger with a sensitivity that we can maybe detect 0.03% of cancers. It's probably not worth it. So the finger is going to go away in near future. Then diagnosis, we have to talk about why is it important to span the bow? If we would have a medication here, 1 tablet a day and the cancer is gone, we would not have to do screening. If we would have a surgery that can cure everybody without side effects, probably the discussion would not be as deep as it is right now as well. So we have to understand that urologists and the whole community will have to work on all phases of the disease to make it really work at the end. So this was the looking for trouble peak. This is the United States when they started to use PSA. They used it on everyone, and they did surgery on everyone. Okay, that was the big problem. You see in the lower curve, that's Great Britain, and up there is the United States. Of course, that was asking for trouble. You cannot just treat surgically every patient that has a small speck of cancer. That's definitely wrong. And on the right side, just again a reminder, almost all patients with local disease still live in 10 years. If you have metastases, it's a different game. So if we want to focus on something, we have to try to treat all the patients before they become metastases. It's also a quality of life issue because those drugs really kill quality of life. So taken together, no screening is not an option. We have the numbers from the United States where PSA screening went down, and now we have higher levels of metastases back. That's not what we want. We have to do something. Probably we'll start off doing something which is not perfect, but we have to do something. So let's talk about Gleason. I know you're all experts in this room, but I still want to highlight some things. So you understand the pathologist gives us a number. We make a biopsy in a cancer, and the number is actually added of 2 values that the pathologist sees, the most aggressive and the most common. That's the basic rules. You add them up, and then you get a number. In this case, it was a 4 plus 3. Equals to a score 7. We call it 7B because the 4 is in the forefront here. So this is the nomenclature that pathologists use to let us know how to decide later on. And we had a problem worldwide that the biopsies that were taken were not taken of good quality. If you just, in the lower line, take biopsies from the back of the prostate, you will clearly miss the prostates out front. You are not targeting the prostates right. And this is unfortunately still common around the world in many places. I know that your country and Switzerland are very modern, and now we're moving away from it. What we have to do is, especially, and that's why I'm here to talk to you about, if you want to do high-tech medicine, you have to know exactly what your patient has. And that can only be performed through a transperineal biopsy, a fusion biopsy, which I'll show you in a second. So how does that really work? The computer aided helps us to define where to put the needles. The overall idea is to stick needles in so narrow that a significant cancer cannot squeeze in between two needles. We will have a nice mapping of the prostate. We have GPS coordinates of every needles. I can even take these GPS coordinates for my treatment if I wanted to. So it really has to be geographically correct. The overall goal is that we get a sensitivity for over 90%, meaning what we get in the biopsy would be the result if I take the whole prostate out and give it to a pathologist. It should match, over 90%. And this is how it would look like. You see on top there's an ultrasound image. We place all the needles. In this case, the MRI showed right and left, some suspicious regions. But then at the end, he only had the yellow cancer, and we treated that. And I'll show you that in a second. Now, what happened when we changed from the old biopsy system to the new system? This is what happened. On the left side, you see the transrectal 12 biopsy, which was standard. We had quite some patients you did a biopsy on that had a Gleason 6, but at the end after surgery, it was a Gleason 8 or even worse. That should not happen anymore. The overall goal would be one green line of balls going down from top left to the bottom right. And you see that we're getting narrower and narrower. It's still between the 7A, 7B, there's some swapping, but overall we're getting very much better. So I know exactly what the patient has, and I can discuss with him his needs. Why should we not treat Gleason 6 cancers? Gleason 6 nowadays is a very strict defined, we would love to call it a precancer. It's a malignant thing in the prostate that does not kill patients. You know, out of 10,000 patients, only 3 died of it in this big study. And if you look at the lymph node, that's also something. A cancer should be able to make metastases. And if we do, there's a number of 14,000 patients that went through surgery, and not one single case of these patients had a metastases. Meaning that probably these 3 + 3 is a different entity. It's not something you can die of. And if it's not something you can die of, you should not treat it, because you will never save a patient's life if they're not dying anyway. Okay? So keep that in mind, Gleason 6. And this is now new, and I'm very proud to be part of this guidelines committee. Now it's clearly stated in the guidelines, we do not recommend any treatment for these patients. Now, I found this beautiful publication out of Norway, and if you look, the blue lines on top, these are age groups, are the Gleason 6 on top. No treatment for those. Then you have a treatment area of the young guys. And then in the older guys, I just dropped it down because I believe if you have a highly aggressive cancer and you're 75 or a little older, you should probably still get treatment. The highly aggressive ones will make metastases in your lifetime, and then you need systemic treatment. So that's why it drops off. But it's about this field that I would say nowadays really need treatment. Now, the patient comes in, you discuss with him whether active surveillance or watchful waiting is a possibility. Keep in mind the quality of life in these are very high. It's not perfect because the patient will still think about his disease, but it's almost perfect compared to other things. Now looking at the treatment options, there's plentyfold, and now you can discuss with your patient what he should or she, no, he in this case of course should get. I usually draw this speedometer for my patients. I tell them where they stand, how fast is this cancer growing. And it used to be that we had low risk equals active surveillance. There was a clear cut and everyone else got surgery and radiation. I'm not so sure whether that's correct anymore, and we have to discuss that. So we do a lot of surgeries with a robot, and it's important for me to convey to you that surgery is still the gold standard in this population. I do more Da Vinci surgeries than I do HIFUs, but I'm the biggest fan of HIFU, and I'll tell you why in a second. So you see with the robot we can work very precise, the data is good, we get smaller incisions into the belly, the patients really profit from going home faster. My last patient that required 1 bag of blood is 3 years back. So really we cut down on blood loss, patients are doing fine. Scientifically, I can only tell you that there's a trend towards better potency and continence, but it's not a day and night thing. A patient should always ask the doctor, what can you do well, and then get that treatment. If you have a doctor who does open surgery really, really well, I would trust him. But if it's a younger guy nowadays, and I know in Norwegian regions as well, the radical prostatectomy is done with the robotic system. So that's what I'm talking about. There must be a middle ground. There must be something that we can offer in between an active surveillance and a full-blown surgery. And that's what we like to call the focal therapy idea. So, and if you look on your graph again, that's quite a big area. I mean, many patients could profit from it. I'm not quite sure if we should offer it to all the younger gentlemen because they still have a long lifetime, but the field is about in this region. And I'm happy to discuss the indications later after our talks. And are we allowed to do this? Do patients want us to take more risks? You all understand, if I take the prostate out, your risk is of course much lower than if I leave prostate in and treat only a small part. But the patients are telling us, yes, please do it. This is a questionnaire that patients were asked, how many months are you willing to die earlier if you don't have this? Okay? And if you look on the bottom line, 27 months are patients willing to die earlier if they never need the diapers, if they don't lose urine. Sex is about 6 months. Then we have severe bowel symptoms is 25 months and so forth. So patients nowadays live long, but they want quality of life now and on a top level. They don't care if they reach 90 or 88 years of age. And that's something that we doctors have to accept and learn. We also look at tumor biology, and this is a very fundamental paper looking where do the metastases come from. And out of 10 patients, in 9, the metastases are produced in the prostate, meaning that there is a lesion, we like to call it the index lesion, which probably causes all the metastases. And if you can kill this lesion, then probably the patient will have a benefit. That's the idea. Rarely you have a lymph node metastases that then will spread. So that tells us if we have a prostate with Gleason 7, which is a clinical significant cancer, and some Gleason 6, we in Switzerland still only try to treat the number 7, the index. The 6 part would go in active surveillance and we'll just follow up on them. We have learned through COVID that you can delay surgeries by many months and the patient is not suffering. There's no disadvantage. Meaning that even if I had a small mistake in my system and I should probably do the surgery to this patient, we have time. If we check up on this patient thoroughly, we will catch him still on time to offer him a surgery later. So what I will tell you about is just treating the aggressive part in the prostate and even leaving the small Gleason 6 cancers there for active surveillance. So how does it work? You see the patient is lying on the side. That's due to technical limitations of the ultrasound. The probe is inserted and I can burn a rice corn into the prostate. The ball that is really dying is about a rice corn size, and you just move the head around. It's a robotic head, and you add one rice corn to the other until you have the area that you want to treat. Overall, it works very much similar as I'm pretty sure you did that as a young guy, holding a lens to the sun and then playing around and suddenly you feel that you burn your finger. So it's just a bundling of energy, and it's a speaker system that can focus really well energy. You see the red line is the rectum wall and the focal point is 80 degrees. Meaning that the rectum does not get much heat, it's even cooled, but the focal point is 80 degrees, and you see it actually leads to a fibrosis. So the tissue dies, and it's sort of a recycling. Your body will then, take this dead tissue, take the protein, and do something smart with it, but the cancer is gone. So that's the setup that we have. Here you see again how we do it with a patient. You see the planning, the yellow part would be the cancer area. We always add 9 millimeters of safety zone around. The 9 millimeters was discovered with 2 publications showing that in the Gleason 7 range, about 9 millimeters of cancers can sometimes not be seen by the MRI, so we add the 9 millimeters to all extents. And that's how it works. And at the very end, you do a contrast ultrasound, proving that there's not one single blood vessel left in the area that you treated. So let's look at the very short video, how we actually do this in the clinic. We work closely with the radiologist with their fancy setups. They actually delineate the cancer and the prostate for us. We get all the data on a memory stick. We place it into the machine. Then the technician helps me setting up everything for the patient. The patient is on the side here, already lying and sleeping. It's usually under general anesthesia. And then the probe is inserted. And then the whole prostate is scanned in 3 dimensions. The whole data is then fused, that we have MRI, needle biopsies, and the ultrasound, all the data together. The cancer is delineated, and then the treatment starts. Okay? You see this white ball is the explosion of cells in that area. During the treatment, we check movement. There's a laser reflector. If any movement happens, it stops. We look at the rectal wall. Any thickening, we stop immediately, of course. I have not had one fistula in my population so far. It works well. And here you see at the very end on the top image is again the ultrasound that was checking exactly are the blood vessels gone in this area, or is there still perfusion? So that's the HIFU system that we use, and at the end you do an MRI and then you should see the hole as well. That's just to prove that everything is well. So I started this idea 10 years ago exactly today. I went to London to Professor Emberton, who is one of the pioneers in this area. And I went back to Switzerland and said, let's do a solid study, but let's do a very critical one as well. So we said we will, number one, any Gleason 7 remaining in the patient, we call a failure, because then the discussion starts again. The number 2 is we treat only focal. HIFU was used, especially in the French population, also to treat the entire prostate. They really just burned the whole prostate with energy. The outcome data are not that good. Actually, nowadays, compared to a nice robotic radical prostatectomy, I find the robots to do a better job than the HIFU. So that's something that we would never do. Just treat focally, and then we ask the patients for 3 full-blown needle biopsies with up to 40 needles per prostate. That's a lot of data. We really wanted to prove, does this system work? Is there a benefit? Can we move on with this? So I will report on 104 patients. 13 were excluded because they were salvage cases. You can also use HIFU if someone has a radiation failure and it's very localized. And there I'm able to cure at least half of the patients. So those are those 13. And then we went through up to 3 years following them up. So if you look on the bottom right, this is the failure. You see that a lot of patients are still happy and do not have a radical prostatectomy, a radiation, or systemic treatment. If you look up there, we have a 100% cancer-specific survival. Everybody who knows something about prostate cancer knows that that's not surprising. Prostate cancer is not the killer, especially not because I select Gleason 7 cases. We have 99% without metastases. I will show you the one case later. And we have 81% after 3 years without radical prostatectomy or radiation. So if a patient comes to me and says, I cannot see myself going through surgery, what can I do? HIFU might be an option in some cases. Now, what are the functional results? And that's exactly where the HIFU really shines. So patients come in a night before HIFU, then we do the HIFU, the next day they go home with a catheter, a week later the catheter goes out, and for almost all patients, the side effects are less than a prostate biopsy. So it's a straightforward procedure. IPSS score on the top left tells you about bladder bothering and stream and flow quality. So the HIFU helps a little bit, goes down, but it's not a treatment for BPH. So if someone has a benign prostate, it's not a HIFU case, of course. But sometimes they still profit. Bowel is just a no problem, no issue. Totally contrary to like radiation, especially during that time. Then if you look at the erectile function, you see a dip at 1 month, but at 3 months they're already going up. And that's where patients are very happy. Most of the patients can tell me they have still intercourse if they were able to have that before. EPIC and the EPIC urinary are quality of life questionnaires as well. It's really good. But the most fascinating is this. We are talking about a cancer treatment, and the overall quality of life goes up. So that means we have patients who are really sad before coming to HIFU, but at 3 years in the population that I studied, the patients are happier than before. And that's very rare in cancer treatment. Usually you have some side effects which is really hurting you, and that's not possible. So overall quality of life is really going up after this treatment. We also looked at complications in very, very much detail. On the bottom part, you see where we treated the prostate. Most of the cancers are somewhere in this region right here. We don't treat really, I don't like to treat them if they're very close to the apex because of course the muscle layer here, which is granting continence. But you see we don't like to treat the anterior part because the whole energy is coming from the back. That's also an issue. And if you now look at the complication rate, you see that these have the highest complication rate and the lower ones are back here. But what kind of complications do they have? It's mainly infections, it's clogging of urinary flow, they need a catheter for a while and then we remove it again. So it's all like minor issues. I have some where I have to go in with an instrument to take some tissue out if there was too much swelling. But it's only like 3 or 4 in these 100 patients. So overall, here are our results. Imagine this patient had a small cancer. The red ball is where we ablated with HIFU. Right now, I can tell you that after 3 years, 64 patients are completely cancer-free. They don't have any remnant cancer anywhere. 30% do have a little cancer. However, it's so small. It's usually 1 to 1.5 millimeters of Gleason 7 in 40 needle biopsy. So it's such a small cancer that we put these patients as well in active surveillance. 8% got a second HIFU. I'll tell you about that and how that is going. And 16% needed a radical prostatectomy. And we do that routinely. The outcome of these radical prostatectomies is very good. But it's only good because we only treat very focally. If you do a big HIFU, it's a very challenging surgery. And I would not recommend that. Okay? And now, so my patients, if they come and see me, they get this chart. And I tell them, if you are a good case, this is your outcome in 3 years. The yellow part is the ones that needed a radical prostatectomy. So for many patients, this is an option. They consider it a one-in-a-lifetime chance to cure their cancer with a very mild system. If it works, okay. If it doesn't work, they accept that they have to go to surgery. I always get the questions asked, is there a difference in the number 7 Gleasons? As you know, there's 7A and 7B. And in my numbers, there is only very slight difference, and it's not significantly significant. So at the very beginning, I told you we don't treat Gleason 6. We did some at the very beginning 10 years ago, and you see they're just doing fine because nobody has a problem with the Gleason 6. And then the other ones are very close to each other. Therefore, in my clinic, if it's a Gleason 7, doesn't matter which way, and it's very focal, we allow them a focal therapy. Keep in mind, and this is something that we as researchers still have to figure out, in 45%, the cancer that we find in 3 years is completely in a different location of the treatment. Meaning that either the cancer was there already 3 years ago and we missed it and it was very small and it grew to a substantial size now, or there's new cancer formation. And that's something that we have to keep in mind. So in 50%, the cancer is at the same location, and maybe the HIFU did not do the job perfectly, but in the other 50%, the cancer comes in another area. And then we have to discuss with the patient whether this is maybe a genomic background, and this patient would rather profit from a whole ablative therapy, meaning a radical prostatectomy or radiation. This is not something for you to read, but I just wanted to show you that every patient we follow up that we do HIFU on. And if you look, there's the re-HIFU cases going up, and of those, I just summed up here the results. 8 patients had a re-HIFU because they were so happy with the first treatment. When the cancer came back, they really asked me, can you treat again? And if the cancer is in a good location, I offer them a second treatment. Of those, 3 were cancer-free after the next biopsy. They always get a control biopsy afterwards. 3 still had cancer and required more, and 2 didn't want any biopsy. Those patients had so low PSA values that they just didn't see any need for a biopsy. And so keep in mind that all the dropouts where we don't have biopsies are usually patients with PSA values of 0.5 or something, which really is hard to convince a patient that he has to get another biopsy. Okay? So usually these patients are going well. So I brought some cases for you to understand that this is still in its infancy, it's science that we have to follow up, and I'm showing you some cases. So this is an 86-year-old patient, 2016, I did the treatment. You see on the very left, the biopsy and the cancers. The cancers are in the red balls. The yellow is a lesion that we ablated. 6 months later, he still had 1 core of Gleason 7B, and because he was below 70, we said, okay, let's do a re-HIFU. We did a re-HIFU on it, and he's remained cancer-free for the entire study. Even longer, now after 6 years, the PSA is still 2.1, so he's with very high probability still cancer-free. So many patients are allowed to have 2 HIFUs if needed. This is another case which is a little more complicated, but I just show you what you have to do, the whole thought processing. We did a HIFU in the yellow zone on the right of the prostate, so on this side. When we did a control biopsy at 6 months, we found 1 core of Gleason 7 on the left side. But because it was so small and the PSA was low, we decided you cannot even see it in MRI, we don't do anything. When we did at 12 months, the rebiopsy, we didn't find that Gleason 7 anymore, we just found 1 Gleason 6 on top. So again, something really mild, and we didn't find it the 7 anymore. And after 3 years, we didn't find any cancer anymore. Now, the cancer is not gone. That is not something that I believe of. But it's such small cancer samples that you can miss them with a needle. Okay? And this patient went up. His new PSA, it's many years passing, is 1.5, and he's cancer-free. But he was actually, I showed you his data as an outcome which was undesirable because he had a relapse of a Gleason 7. So even in the relapse population, I have many which are happy overall in the long term. Okay? So we have to keep that in mind. When you look at these things, always think of this as well. These are autopsy data patients who had car accidents where we didn't know they have prostate cancer, in the white population in Europe, you find over 30% of men, if they're 70 years of age, having prostate cancer. And those are just randomly found cancers. And of course, if I sample a patient, oh, no, that was too fast. If I sample a patient that many times, that's 120 needles in the prostate. Of course, I will find something. And I always have to account for that as well. If it's not visible on MRI and it's very small cancer, it's probably not going to kill the patient. And here's a special case. That's the one with metastases I had to report on. This patient still comes and sees me. Now it's 10 years since the treatment. And I always tell my nurses, this is my worst case in the HIFU series. And he just walks down the aisles and comes and sees me. Let me tell you the story. So 67 years of age, he had a PSA of 7. There was a Gleason 7B, a fairly big one on the left side. So we treated him with HIFU. And it went all really well. He came back, 6 months, no cancer in the biopsy. 12 months, no cancer in the biopsy. I was clapping his back and said, you're cancer-free. But then we realized, even though the MRI was always negative, his PSA was just rising. And at 3 years, he had a PSA of 20. So of course, that is not a good sign. Okay, if PSAs, as a rule of thumb, PSA of 20 is usually some sort of a metastasis. Probability is very high. So we did PSMA PET imaging, and what I can show you here is that, yeah, it's true, the prostate doesn't have any cancer, but you see these dots, and now there are more dots. The prostate always remains cancer-free. So this guy came to me at a time point where he already had a lymph node, at least 1 or 2 lymph node metastases. I was able to kill the cancer in the prostate, but I was not able to cure the ones in the lymph nodes, of course. Now, if you ask me, would it be wiser to do a radical prostatectomy on this guy at the first stage? I cannot give you a definitive answer. I'm not sure I would have cured him with a surgery either, because the spread was already there. But we all know now that in a certain subpopulation, we do radiotherapy to the prostate, even in metastatic setting, because they profit. And that is what's happening here as well. This patient now is still coming to see me. He's under ADT for 6 months now with a PSA of 0.7. And because he's now 82 years old, he just goes on intermittent ADT and he's still very happy. Okay? So this is a special case. Maybe even I was able to prevent further metastasis formation by doing this HIFU on the case, if we believe the index theory is true. So in conclusion, if you work very precise, and you have to do it for HIFU, you have to use modern biopsy technologies, MRI imaging, maybe in the future even genomic testing, then you can offer a HIFU to a certain amount of patients. But you have to select them very carefully. My number is 1 out of 4. I see 4 patients coming and asking for HIFU, 1 gets the HIFU. The 3 get the surgery. Because of course the patient wants the mildest treatment, but I cannot offer the mildest treatment to everyone. Then it's suitable mostly for smaller cancers. I like if the patient is already 65. Again, the lifespan that makes a difference. I do treat 7Bs and 7As if a PSA value is below 15. And the biopsy, the early rebiopsy is crucial. You saw that there was a fairly amount of patients who needed radical prostatectomy, but those we caught within 6 months to 12 months after the HIFU by doing a solid check. If they had significant cancer, there was not a big discussion. They understood that they have to go to surgery. So I actually had a convention about a month ago. I invited all my patients back that were in the study to tell them the study results. These are all my patients. They all came. They're all fascinated by the technology. They want to really, they live it. They want to know what happens to their system. And it's now at the point where even the Swiss government is paying for this treatment if they want it. So thank you to all the patients that participated, but also thank you for your attention. And I hope I was able to show you how we do it in Zurich. Thank you so much. you.